Hello, everyone. Thank you so much for coming to our webinar today, which is Understanding Gaps Between Adult Medicaid Beneficiaries and Dentists. And it is being presented in part by the ADA Health Policy Institute and the American Dental Association. My name is Ian Hedges. I'm the Director of Medicaid and Medicare Program Policy at the American Dental Association. I will serve as today's moderator. However, we do have a full agenda today. Our first presenter who's going to talk about the Medicaid pilot program that we are operating is Matt Zaborowski, our Senior Manager of Medicaid Programs and Health Policy. Our second presentation is going to be around the data that we are presenting today about adult Medicaid beneficiaries and dentists, their perceptions and their experiences with the Medicaid dental benefit. And then that will be followed up by a question and answer session with several of our panelists who have been involved with the Medicaid pilot program at the American Dental Association. The panelists I want to introduce are Dr. Hal Jeter. Dr. Hal Jeter is the current president of the Ohio Dental Association and is a general dentist practicing in Southern Ohio. He has been a Medicaid provider for almost 30 years and sees treating Medicaid patients as a way to give back to his home community. Ms. Helen Hockey is the executive director for the Pennsylvania Coalition for Oral Health and has held multiple posts with other oral health related advocacy groups over the last 20 years. Her work aims to improve health behaviors among the public and help providers become more proactive advocates for better oral health. Mr. Matthew Ballard is the Deputy Director with the Division of Medical Services in the Department of Social Services, which is also known as South Dakota Medicaid. In this role, he leads policy development and innovation, as well as the agency's data analytics and care management programs. His team manages South Dakota's Medicaid's dental vendor contract and collaborates with the dental vendor on coverage, reimbursement, and increasing access to dental services. Right now, I would like to turn it over to my colleague, Matt Zaborowski, to talk about the Medicaid pilot program.
Thank you, Ian, and thank you everybody for joining us today. As Ian said, I'm going to talk about our Medicaid pilot project and start the webinar off. In December of 2023, the ADA's Council on Advocacy for Access and Prevention Medicaid Advisory Committee determined the need to advance Medicaid, addressing the administrative burdens, the limitations, and barriers within the system, and wanted to provide improvements to support access to care. So with that, we aim to increase provider participation and beneficiary utilization of dental services for children and adults through a pilot project through December 2025. In doing so, we identified 6 states and wanted to create a comprehensive report at the end of this pilot project to outline the successes, strategies, and outcomes of these 6 states. In doing so, we hope to achieve increased provider participation and increased utilization of services for both children and adults. The 6 states that were selected were South Dakota, Nebraska, Ohio, Pennsylvania, Rhode Island, and Maryland. These states were selected based on a variety of factors, including the variance in the number of managed care organizations that they have, the robustness of oral health services and Medicaid coverage, either potential or recently implemented fee increases, differing demographics of their oral health workforce, proximity to a dental school, and several other factors. The project has been broken down into 3 phases. In doing this, we hope to create a streamlined approach as we move forward towards these shared goals. Phase 1 was created based on the formation of the state teams. These state teams ideally would include the State Dental Association, the Oral Health Coalition, the Department of Health, including the Division of Oral Health, and the Department of Medicaid. Ideally, we would also include providers, as well as other key Medicaid stakeholders and advocates. In forming these states, most often the Dental Association, Coalition, and State Oral Health Program determined which stakeholders would be invited to this group. As Phase 1 was being formed, the ADA shared the vision of this project, inquired about existing strategic goals related to Medicaid participation, and helped facilitate a state-specific approach. In Phase 2, We reviewed the three core goals of the ADA for this pilot project, which I'll go over on the next slide, and then identified state-specific sub-goals, strategies, and an action plan to achieve such success. Again, forming these states and throughout the entire project, the ADA serves as the convener, the facilitator, and the states are the ones that are driving their shared vision and their goals to align for success. As phase 2 is ongoing, we enter into phase 3, where we form a collaborative. We meet quarterly between all 6 states, ADA staff, CMS staff, including Dr. Natalia Chalmers, the Chief Dental Officer. This allows the states to share their progress, updates on quality improvement projects, and allows for collaboration and discussion. As I mentioned, all 6 states have been charged with a similar goal. The 3 goals that the ADA has formed allows each state to adapt these and move towards their state-specific needs, infrastructure, and their abilities. With that, and through this pilot project, the ADA aims that by December of 2025, we will increase the number of providers, we'll increase the number of meaningful providers, or those that are seeing more than 100 Medicaid beneficiaries per year, and we will measure the change in utilization of services. In early 2026, we will release a comprehensive report or blueprint outlining each state's success, their strategies, lessons learned, and suggestions for other states. On behalf of the ADA, I want to thank each of these 6 states for their stakeholders and my colleagues for the success thus far, and I'm excited for you all to learn more about these outcomes and the report that will come out in 2026. Stay tuned, and I hope you will enjoy the rest of this webinar today. With that, I will now turn it over to my colleague, Brittany, who will take us through the update and the presentation from our Health Policy Institute on the most recent survey.
Thank you so much, Matt. Hello, everyone. Thank you for joining us. In order to assist states with setting and achieving these goals related to dentist participation in Medicaid and dental utilization among adult Medicaid beneficiaries that Matt just outlined, the ADA's Health Policy Institute initiated a survey of adult Medicaid beneficiaries and dentists in these pilot states to sort of get to the root of the matter as to why beneficiaries don't go to the dentist more often and why dentists don't participate in Medicaid to a higher degree. I'm going to go over those survey results with you. A quick word on HPI. If you're not already familiar with us, this research arm of the ADA collects and analyzes data and publishes on a lot of topics concerning the U.S. dental economy. Next slide. The aim of HPI's research is to help guide policymakers, oral health advocates, and other stakeholders in their efforts to address inequities in healthcare access. Next slide. So on the basis of the survey we sent out to beneficiaries and dentists in our 6 pilot states, plus 2 other states that HPI added to enhance data quality, we drafted 2 research briefs exploring the results and their policy implications, which we will also discuss today with our panelists. These research briefs, along with the PDF reports of the full survey results, are all available for download on HPI's website. Next slide. For a bit of further background behind this whole project is looking at the different levels of dental benefits that states have. We estimate that as of mid-2024, most states have what we would consider enhanced dental benefits for adults in their Medicaid program. Enhanced benefits means that most types of procedures are covered and the annual maximum per beneficiary is at least $1,000, or there's no annual maximum at all. The states that we surveyed for this project are outlined in yellow. So we have the 6 pilot states that Matthew brought up, plus 2 others, Minnesota and New Hampshire, which we chose just to augment the data. So as you can see, even among our target states, there is enhanced coverage for adults. But the dental benefit that Medicaid programs offer is not the whole story. Even with enhanced benefits, barriers to dental care and barriers to participation for beneficiaries and dentists persist. And our survey is meant to figure out what are the reasons for that. Next slide. We sent out the surveys to beneficiaries and dentists around this time last year. We gathered nearly 2,500 responses for beneficiaries and 1,000 responses from dentists. The number of responses varies by state. We surveyed adults 18 years or older who confirmed that they are enrolled in their state's Medicaid program. And we surveyed dentists regardless of their current or past Medicaid participation. Next slide. The first set of results from our survey concerns adult Medicaid beneficiaries in the 8 states. We asked beneficiaries if they had been to the dentist in the past 12 months. Around half of our beneficiary respondents said yes, they had. But among those who had not been to the dentist in the past 12 months, we asked them the reasons why they do not visit the dentist more frequently. The barriers to dental care fall into 5 main categories: provider access, affordability, fear and anxiety, no perceived need, and other. Among beneficiaries in all 8 states, provider access was the most frequently cited barrier to dental care, followed by affordability. These results vary a bit at the individual state level, but overall, we see that provider access is a formidable issue when it comes to getting to the dentist. Let's take a closer look at what that means. Next slide. Provider access issues include inability to find a dentist who accepts my insurance plan. That's the most common access issue for adult Medicaid beneficiaries. Others include inability to travel to the dentist or inability to find the time to do so, indicating that dental offices may not have convenient appointment times or locations. Other barriers under provider access include difficulty finding where to go for dental services and difficulty finding a dentist who speaks my language or is of my background. So a lot of these issues indicate that the pool of Medicaid providers who are able to accept new patients may not be large enough. Next slide. Affordability is the second biggest barrier category for beneficiaries. Affordability issues include not enough services being covered under their insurance plan and inability to afford any out-of-pocket costs that might arise from treatment. Some of the barriers that beneficiaries cite have an equivalent among the dentists we surveyed. Dentists share some of the same frustrations with the Medicaid program that beneficiaries do, and it plays a big part as to why they do not participate. Next slide. In our survey of dentists, we asked them to rate the importance of particular barriers to Medicaid participation. So we were essentially asking dentists who do not treat Medicaid beneficiaries why they do not participate at all. And we asked dentists who do treat Medicaid beneficiaries why they don't treat more beneficiaries than they currently do. This graph represents those who selected important and extremely important to the response, how important are each of these factors in keeping you from treating more Medicaid patients. The purple bars represent all of our dentist respondents, while the gold and teal bars break down dentists who do and do not treat Medicaid beneficiaries. You can see that for nearly every barrier, dentists who do not treat Medicaid beneficiaries, that's the teal bars, were more likely to rate these barriers as important or extremely important compared to dentists who do treat Medicaid beneficiaries. For all dentist groups, the reimbursement rate of Medicaid is the top barrier, followed by appointment cancellation and no-show rates among Medicaid beneficiaries, and denial of payments by Medicaid. There are a few barriers where we see a larger discrepancy between the two dentist groups. Dentists who do not treat Medicaid beneficiaries tend to be more concerned with the claim submission process, the time it takes to get reimbursed by Medicaid, and the possibility of their practice being audited compared to dentists who do currently treat Medicaid beneficiaries. You can see how some of these barriers to participation cited by dentists align with the barriers to care expressed by beneficiaries. Around 8 out of 10 dentists say that Medicaid does not cover a comprehensive array of procedures, which is one of the affordability issues that our beneficiaries cited. My insurance plan does not cover enough procedures. Dentists citing the appointment no-show cancellation rate may also be reflective of beneficiaries' struggle to find the time or means to travel to the dentist. And issues with reimbursement, whether it is low, denied, or delayed reimbursement under Medicaid, may in turn create prohibitive out-of-pocket costs for beneficiaries. Next slide. An important aspect that might also be keeping dentists from participating in Medicaid is their current workload. Among all the dentists responding to our survey, 60% said that they are either too busy to treat all patients requesting care, or that they treated all patients requesting care but were overworked. When we look at dentists who currently treat Medicaid beneficiaries, 67% report being overworked, compared to around 50% of dentists not currently treating Medicaid beneficiaries. So essentially, dentists participating in Medicaid tend to feel overworked. Next slide. As a follow-up question, we asked dentists who reported being overworked if their workload is the result of staffing difficulties in their office. In other words, the inability to hire enough qualified staff, which is something that dentists have been struggling with over the past few years. We don't see as sharp of a difference between the two dentist groups. Around 60% of dentists who do and do not treat Medicaid beneficiaries said that staffing challenges are extremely or very much a factor in why they are overworked. Next slide. So far, we have discussed the program level issues that beneficiaries and dentists struggle with when it comes to Medicaid. The next section of the results goes a little bit beyond these program level issues, looking at some of the attitudes and perceptions held by beneficiaries and dentists. Among adult Medicaid beneficiaries, we see that by and large, they value their oral health. 8 out of 10 agree that the condition of their mouth and teeth is essential to their overall health and to their appearance. 3/4 agreed that it is important to them to keep their natural teeth. Among dentists, between 1/5 and 1/4 agreed or strongly agreed with the statement, Medicaid beneficiaries value oral health. It should be noted that slightly more dentists who do participate in Medicaid agree with this statement. So essentially, we're seeing a bit of a disconnect here between beneficiaries' expressed values and dentists' perceptions of those values. Next slide. So while beneficiaries report that they value oral health, they might place a slightly different value on dental visits. Around 1/5 of our beneficiary respondents agreed or strongly agreed that going to the dentist is not worth the cost, meaning most agree that it is worth the cost. However, around half of beneficiaries agreed or strongly agreed that going to the dentist is only worthwhile if they are experiencing pain. So these two results together might indicate that beneficiaries may not necessarily see preventive dental visits as worth the cost, but only those to treat acute issues. Dentists, for their part, were not likely to agree that Medicaid beneficiaries comply with treatment plans. Again, we see that dentists who currently treat Medicaid beneficiaries were more likely to agree that beneficiaries comply with treatment plans. Both groups of dentists agree nearly equally that it is challenging to provide comprehensive treatment to Medicaid beneficiaries compared to their other patients. Next slide. So while not as many beneficiaries agree that going to the dentist is worth the cost, and beneficiaries' hesitancy to go to the dentist may reflect some gaps in oral health literacy. We also surveyed our beneficiaries about the health habits they follow at home. Around half of beneficiaries reported that they always or most of the time brush twice a day with fluoride toothpaste. Two-fifths said that they always or most of the time floss or clean between their teeth daily. Around one-third that they said they always or most of the time drink tap water instead of bottled water. Two-fifths report that they never or only occasionally use tobacco products. And one-fifth report that they consume sugary foods and beverages no more than once a day. Hesitancy to go to the dentist and maybe some less than ideal habits at home most likely translate to more severe oral health outcomes. And 8 out of 10 dentists who treat Medicaid beneficiaries agree with this, that oral health problems are more severe for Medicaid beneficiaries compared to their other patients. And they agree with this even more so than dentists who do not treat Medicaid beneficiaries. Dentists of both groups agreed equally that Medicaid beneficiaries are culturally more difficult to treat compared to their other patients. So these were the principal survey findings that we went over in our research briefs that I mentioned and that we wanted to discuss in the webinar today. Please do refer to the full survey reports that we have for the entirety of what we covered in our surveys. At this time, I'm going to hand it back over to my colleague, Matthew Zaborowski, to sum up what these results tell us.
Thank you, Brittany, and thank you for the fantastic work that HPI did conducting that survey and walking us through those results. As you can see, the research is very enlightening and provides great insight. As Marco recently said, this research sheds light on how we can improve access to care for Medicaid adults, and why this is groundbreaking research from the aspect of gauging perceptions from both existing Medicaid providers and those that are not, but also understanding the perceptions of beneficiaries and how these values may differ. This actionable research teaches us that the main barriers to dental care for adult Medicaid beneficiaries is provider access and affordability. We know that not every state currently has a comprehensive adult dental benefit, and some offer little to no coverage. As you heard, beneficiaries report difficulty finding a dentist who is participating in Medicaid and has a convenient location or appointment times. Beneficiaries also cite out-of-pocket costs and the lack of procedures covered as an additional barrier. We also see that dentists share these barriers, which are reflected to the beneficiary perception with the lack of comprehensive coverage. In addition, dentists state that appointment cancellation and no-show rates or delayed and denied reimbursement may often be a barrier for treating Medicaid beneficiaries. But we have found from our current Medicaid research is that providers oftentimes do have a misconception or a myth about cancellations that exist in this population, and may actually not be true, and that regardless of insurance type, canceled appointments and missed appointments often take place. These must be, providers must go through a procedure and a policy in their office to help to ensure cancellations and missed appointments are not taking place. The ADA is going to be releasing with the recording of this webinar 2 one-pagers that will address both missed appointments and strategies on how to overcome those, and also have some tips and tricks to try to reduce the number of denials. We know that the current workforce is currently overworked, and the perception reiterates this, and those providers who accept Medicaid report just that. I want to reiterate that 8 out of 10 beneficiaries agreed that the condition of their mouth is important to their overall health and appearance. Gaps in oral health literacy or hesitancy to seek dental care does not mean that beneficiaries do not value oral health. I also want to reiterate that this is the time to change our perceptions and the idea that low-income adults do not seek care because they don't value oral health. There may be a disconnect between dentist perceptions and reality when it comes to patient attitudes. I hope you all will take the time to review the research briefs in greater detail that Brittany outlined for you today. I'll be placing in the chat shortly a link to those research briefs where you also find the recording of this webinar in the next several days, as well as those two those two white papers that I mentioned. I hope this presentation so far has intrigued you and you will review those research briefs. With that, I'm now going to ask Ian to facilitate our panelist discussion and ask our panelists to come back on camera as we move through the question and answer session.
Thank you so much, Matt. Thank you for those enlightening findings. And I am now going to ask our panelists several questions related to some of these findings as well. So my first question is actually going to go to Helen. So as a leader in your state and representing an organization that facilitates collaboration with stakeholders, how do you engage with your coalition building to create a shared vision to improve access to care?
So, Ian, that's a great question. I may be biased, but I believe that state oral health coalitions are pretty special unicorns in this space, since we really try to merge the goals of not just the people seeking dental care, but also the providers who give the care, the funders and the insurance plans who pay for it, and the government agencies who set the policies and the structure for care. So we're actually tasked with bringing all of that together and saying, just as you said, a shared vision. So it's sometimes difficult to reach. What has really been most helpful to us is to share data that demonstrate the problem. So, for example, we can use the ADA data now and combine that with our own story bank. So we collected stories from directly affected people and got anecdotal stories from those Medicaid members. And we can now use that data from the ADA and the personal stories to find some links between everyone's goals. So as you all know, Medicaid access is a pretty wicked problem. We've got budget issues, provider issues, access issues. And so at the local level, we're really able to connect with members who rely on Medicaid for their health care by really working with the agencies that are already working closely with them. So our federally qualified health centers, our community health workers, our Head Starts. That's where we really have to listen, and the listening comes in. It's very, very important. So when you listen to the stories, you can find those common themes and start to figure out ways that your team can address those problems. So we connect those ideas with our state decision makers and even work with national groups. So ADA, CareQuest, the Open Network, and that all helps us to build the right team to really affect change in this space.
Thank you so much, Helen. My next question is for Dr. Jeter. As a Medicaid provider and with your involvement in organized dentistry, how do you think that this data aligns with your experiences and the experiences of your colleagues?
Thanks, Ian. And let me first say that my comparisons to this data in our state are going to be compared to a comprehensive survey of our members that the Ohio Dental Association conducts every several years, the most recent being last year. So with that being said, we do firmly agree that a huge barrier, about 86% of the respondents who do not take Medicaid say that the reason they do not is low reimbursement. And so I think that's pretty much an across the board given for folks who do not want to participate in the Medicaid program. The next one in our survey was the patients not showing broken appointments, missed appointments, and things. But that was only 20% of the respondents versus the 86%, a little bit of a dramatic difference there. I can say in my practice, just anecdotally, that the no-show cancellation rate is really no different with the Medicaid population versus the non-Medicaid, whether they be private pay or commercial insurance or things like that. We're thankful for that. Let me say one more thing about our survey. In our state, only 18% of the respondents indicated that they are Medicaid providers, and that is the lowest since we started asking that question in 1994.
Hmm.
As
Yeah.
far as the rest of the perceptions and things like that, varying degrees of confluence with that, but definitely agree that the low reimbursement was a huge barrier.
Thank you so much for sharing with us. And Matthew, I want to ask, just as a state Medicaid administrator, How did this data impact your existing knowledge of Medicaid or the way that the benefit is implemented in your state?
Yes, thank you for the question, Ian. Certainly, I think this aligns with some of the anecdotal information that is provided to us in terms of the importance of reimbursement for dentists, as well as concerns about appointment compliance and staffing and workforce challenges being important as well, and providing a barrier at times. From the recipient perspective, certainly I think some of the access to care information aligns with what we hear as well in terms of the challenges finding a dentist that will accept Medicaid, as well as challenges related to transportation. So I think it certainly aligns with a lot of the areas that we've put a focus on and emphasis on in terms of trying to increase access, and kind of reinforces some of the anecdotal information that we already had.
Yes, well, one last thing I wanted to say is to everybody, we are going to do another round of questions with our panel, but please feel free to submit questions in the Q&A, and we will answer them after our questions for the panel, including about research methodology and the availability of these slides. They will be available, and this webinar is being recorded and will be distributed afterwards. My second round of questions is actually it's going to go back to Dr. Jeter. And I would say, how would you use this data to engage with your colleagues to discuss these perceptions and just encourage more providers to accept Medicaid?
Thanks, Ian. I've been anxious to answer this question, so I'm glad to get to this point because it gives me the opportunity to talk about Ohio in a unique way. After 23 years of no substantive increase in Medicaid dental reimbursement through diligent efforts on the part of the Ohio Dental Association lobbying efforts and other interested parties, we finally convinced the Ohio General Assembly that this was a huge access to care problem. Dentists simply could not afford to operate their practices using fees that were current 23 years ago. So in response to that, the Ohio General Assembly increased the budget by $207 million per year, which amounted to a 93% increase, 93% increase in dental benefits for Ohio Medicaid recipients. We were thrilled. So that gives us a basis now to go to our colleagues and talk about why it is beneficial to become a Medicaid provider. In my mind, there are three things to talk about. Number one, there's a need. Of Ohio's 11 million plus residents, 3 million of those are Medicaid recipients, thereabouts. There's a huge portion of that, as we talked about, who do not have access to the dental health care system. Big barrier to that, dentists just simply could not afford to do it, and I was one of them. I'm a firm believer in you take whatever gifting you've been given, whatever skills, whatever talents, whatever you have to share with someone and use it to enhance someone else's life. And as a dentist, I feel that very strongly. So one of the things that I always talk about when I'm speaking with colleagues in this discussion is there's a need to give back. There's a need to give back to the community. You've been given the opportunity to be a professional in this community. There's a need to give back, and this is a way to do it. Secondly, because of the increase, and there are multiple stories of my colleagues, again, who have benefited. No one's making money doing Medicaid, but we can finally afford to do it. We can finally afford to be sustainable with this increase. So that's certainly something that is an enticing, discussion point as well. And then the third thing is, if everyone would do their fair share, then it wouldn't be overloading to anyone. If we all did the little bit, there's been a myth in Ohio, well, not a myth, but a perception that if you take one Medicaid patient, you have to take them all. Not true. With the managed care, we have 7 managed care organizations who administer our Medicaid in Ohio. You can take a family, you can take 5 families, whatever. You don't have to overload your practice. Take what's comfortable for you, but please take someone. And that's my plea to any Ohio dentist who's watching this today. Do your part, do the right thing, and everyone benefits.
Agreed. And Dr. Jeter, I would just have a follow-up question for you, which is, I think we are seeing this mostly through all pilot states, but would you agree with this, that everybody has to act after an increase is implemented in Ohio. We can't, or in other states, we can't just expect that when the increase is happening, we put it out there to our dental association, the dentist will find out. It requires a lot more proactive engagement from all partners in order to break the years long myth that the reimbursement rate is too low or the system just has too many audits and it's not worth it. Would you agree with that kind of in this new experience or over this new year since the increases occurred?
Absolutely, Ian. We have to be very intentional, and the Ohio Dental Association is being very intentional on preaching that story, on letting our dentists, our member dentists, know that this is a beneficial thing for you. This is a beneficial thing for patients. We have to give the Ohio legislature a reason to be glad that they did what they did. We have to give them a reason to see the benefit to their constituencies that this is a good thing for the state of Ohio. Anecdotally, when I first received the proposed Medicaid increase fee schedule, I happened to have some other commercial fee schedules on my desk for another reason. And I just said, let's see. I can tell you that in many cases, the increased dental benefit for Ohio Medicaid met or exceeded what current commercial insurances were paying in many cases. And I can tell you one that sent me an increased proposal just recently, and it's still below in many procedures what Medicaid is paying. So again, no one's getting rich, but at least we can afford, to do the right thing.
Mm-hmm.
And we need to be very intentional about that message. Yes.
Yeah. Well, thank you very much. Matthew, my question for you is, how do you think states can use this data when thinking about their managed care organizations, their dental carve-outs through pre-ambulatory health plans, or even their single payer administrator contracts, or when broadening access to their state's Medicaid beneficiaries?
Yeah, I think this data can certainly inform those contracts. In South Dakota, we have a TPA contract with our dental vendor, Delta Dental of South Dakota. And so some areas that I think are important are certainly administrative simplicity and trying to align with commercial coverage. I think reimbursement, it doesn't specifically fall under that contract, but the reimbursement that we set is very important in South Dakota. We had a substantial increase recently as well, where rates were rebased to 70% of billed charges. So I think that's been an important step in our state. Our contract includes care coordination provisions. So Delta Dental provides care coordination services that can help dental offices where they are experiencing challenges with appointment compliance issues. And then, network development and provider recruitment, I think, certainly are important to that access. So with that rate increase, we did see increases in enrollment in Medicaid. And our dental vendor also does hands-on outreach and recruitment, visits offices, and through their foundation also has a loan repayment incentive program that's been successful in recruiting new dentists as well.
Thank you, Matthew. And my last question before we get to audience questions is to Helen, which is how would you use this data to support legislative or regulatory changes? And how would you measure success?
Well, I can speak for Pennsylvania and say, one of the first things that we've been able to do is to really leverage it in conversations against our network adequacy rules. And I'm assuming that most states will have something on the books in this space. But, we have a law that says you have to have an adequate provider network for insurance plans. You can't sell insurance or offer insurance that doesn't have an adequate provider network. And so shortages of providers in these networks and seeing that so many people are struggling to access care really helps us to demonstrate the need for our General Assembly to buy in and to try to keep the state in compliance. And so I think that that's sort of a first step there. The ADA findings that, a more extensive coverage offered for adults enrolled in Medicaid would increase provider acceptance was pretty important. We've been without a full complement of comprehensive services here since 2011. That's when our benefits were trimmed back. And we've really seen no increase in the number of providers accepting Medicaid since then. So we've been very, very stagnant in that space. So success for us has to be really incremental. We've been advocating for, nearly a decade on this. We measured success in 2023. We were fortunate to have a bill finally introduced to restore the dental benefit. We measured success in 2024 by the fact that it gathered bipartisan support in both of our chambers. And in 2025, I hope that our measure of success is that the bill is reintroduced in both chambers and passes the whole way into law. Um, but the other thing I want to mention in this space is that, in our state, we work with nearly a 100% managed care system. So we've got 6 MCOs, and interesting to hear about Ohio. And I thought we had the most, but maybe not. And our state publishes a dental fee schedule, but our MCOs don't have to follow that fee schedule. So they can assign fees that are higher or lower than the published ones. And so knowing now what we have learned about the need for increased reimbursement, we can see a need to set some established minimums in addition to advocating for higher rates. So it's not just higher rates, it's making sure that we've got parity across the system. So having Pennsylvania join the pilot, for us has been a great way to measure success. We're going to be able to now look at the numbers of the providers and based on these goals that we've set to make sure that we're meeting the needs of the people enrolled in Medicaid. So.
Well, thank you, Helen. We are now actually going to go towards all of our audience questions. If our panelists would not mind staying on, because some of them are directed to you, but also to Miss Brittany Flynn, I think my first question, there are a lot of questions just about the survey methodology. For example, how were the participants for the survey selected? The second question is if barriers included in the social determinants of health, if the barriers included social determinants of health among the survey questions. Another question was actually going to be about how much did we account for bias in terms of were some of the answers able to be open-ended? So if you wouldn't mind speaking to the methodology of the research and the data, that would be wonderful.
Sure, I'll just kind of give some quick answers to those. And our methodology, by the way, it's detailed in full in the research briefs under the section project background and data and methodology. So the way that we recruited beneficiaries was through the platform we use, which is Qualtrics. That was how we instituted both surveys to the beneficiaries and to the dentists. So Qualtrics was the one that recruited the respondents for us through their online panel partners. And for survey design for beneficiaries, it was mentioned the social determinants of health. We use some past surveys that we have done in the past for surveying consumers based on oral health impact profile in the oral health values scale. So that was how we composed the questions for beneficiaries. And for dentists, we developed the survey internally using feedback from just some of our colleagues in other centers of excellence here at the ADA. We heard a lot from dentists themselves about what are some of the key issues in terms of participating in Medicaid. So we did use, some pre-established survey parameters for beneficiaries, and then we developed our survey internally for dentists. That's that background. What were some of the other questions I'm forgetting that you just asked?
The other one was just, was there any account on the survey of the beneficiaries about bias or prejudice that they might experience? And also if they were able to give open-ended comments besides the responses that were outlined.
Right. Yeah, we did not ask about bias specifically in the survey. And we did not have any, if we did ask any open-ended questions, we did not include them in the report.
Okay, thank you very much. We actually have a couple questions, but the last question is actually, what was the response rate of both the providers and the beneficiaries?
So for the beneficiaries, we got around just under 2,500 total responses, and this varies from state to state. And among dentists, we got 1,000 responses just about. For some of our smaller states, the response rate was a little bit on the low side. So I just would definitely emphasize just keep that in mind when you're reviewing the state level results that are also going to be posted on the ADA website.
Okay. Well, thank you very much. And yes, most of these states that were surveyed do have comprehensive adult Medicaid benefits now, which is partially why they were selected. I actually have a few questions for Dr. Jeter. So we're going to round you up. One question is, how did you convince the Ohio General Assembly to increase dental benefit coverage or the reimbursement? Was it a cost benefit analysis? What were some of the strategies that you all used in order to make that case?
Let me answer one thing the one example you gave, cost benefit analysis. When you compare the cost of a person going to the hospital emergency room with a non-traumatic dental condition, what that cost, what the incurred costs are for the imaging, if they decide to do a CT scan, for whatever they do and not receive definitive treatment, and maybe go back 2 weeks later with the same thing versus going to a dental office, having the treatment rendered, which is probably an extraction, something like that. It was huge, huge disparity. And so we were able to make that point. The main thing that we benefit from in the legislative arena is that the Ohio Dental Association has a very robust advocacy arm. We have purposefully and intentionally made meaningful relationships with our legislature. It's not like we will always go and say, give me, give me, give me, give me. It's like we're saying, okay, we have this problem. We want to help your constituents. We want to help you help your constituents, and this is the way that we need to do it. So, meaningful relationships and advocacy. We were able to, again, when you're speaking of the fiduciary part of it, what business can operate on 23-year-old production, 23-year-old, cost recovery fees? It's just not sustainable. And so we were able to speak from a business model standpoint as well. But again, ultimately, it's an access to care thing. And we were able to put forth the message that there was, again, a huge portion of the population, way too many, who were not able to find a dentist because there weren't very many dentists who were taking any new. I mean, you may have this number of people who say they're Medicaid providers, but the question that's not being asked, that's underlying, is, are you taking any new Medicaid patients? And that's a very different question. I may be a Medicaid provider, but I can't afford to take any new ones. So therefore, the access to care on my end is zero. So we tried to put all that into a very meaningful, very concise message to the legislature and just say, this is reality and we need to fix it.
Thank you. And there was a follow-up question. Did the Ohio General Assembly increase the dental benefit coverage as well, or just the reimbursement? The coverage was comprehensive for several years, correct?
That is correct. We
Yeah.
we lost it briefly in the early 2000s. The adult dental benefit was trimmed back tremendously in the early 2000s, again due to robust lobbying efforts, on the ODA's part and others. We were able to have that restored. So we've had comprehensive benefits for, upwards of 20 years. So no, to answer your question, there was no increase necessarily in the amount of procedures. Although anecdotally, I think there may be a little bit, that we're at least finding it a little bit easier to have some procedures approved from a pre-authorization standpoint. But the big deal is that the 93% increase raised our reimbursement for Medicaid to about 63% of UCR.
Okay, that's good to know. And there have been a lot of questions for you, Dr. Jeter, but I will get to other panelists, which are the question was, what is about your no-show rate? One, two, do you have any insight as to how you are doing with your missed appointment rate? Like, are you doing something you think is going out of your way or something special in order so that disparity, doesn't exist between the no-shows of Medicaid beneficiaries and non-Medicaid beneficiaries?
we just try to preach the message of the value of oral health to every patient who comes in the office. And so that's why it's necessary that you keep these appointments. We do all the practice management things. We send out texts and emails utilizing that medium to remind patients of their appointments. They can confirm online. We still make the phone calls. We just do all those things as diligently as we can. And fortunately for us, it's been productive. And I mean, it's not to say that we don't have no-shows and missed appointments. Of course, life happens to everyone. So if you wake up sick that morning, you're not going to make your appointment. But in the sense of the volitional, I'm just not going to go to my appointment. Fortunately, we've been able to curb that because, one of the things we do is we have a stated policy, an office policy, which outlines you're able to miss 2 appointments before you're considered for what we call inactivation. And then if those 2 appointments are missed and there's not a great reason, we try to be as compassionate as possible. But if they're just missed because they're missed, then they are dismissed from the practice. So,
well, thank you very much, Dr. Jeter. I think I might have one follow-up question for you later, but I actually wanted to turn over to Matt. So of course, someone wanted to share congratulations to both South Dakota and Ohio for getting your Medicaid dental reimbursement rates up. I think that again is huge. The question was, did you, when you increased your reimbursement amount, Matt, did that also increase the federal match or what is known as the FMAP as well? And I believe someone is asking that so that they can make that case when approaching their legislators.
Yeah, so the FMAP is a static percent. It changes year to year, and so then it also varies by some other things such as recipient. And so, right, because the fees are higher, you're bringing in more total federal dollars, but the percentage doesn't change just based on the rate increase. But because the rates are higher, there would be more federal dollars than associated with the payments.
Mm-hmm. And this question is actually for all panelists. I know that many of your states are going, they're not only talking, the reimbursement rates are done, but what a lot of you are talking about is education, but also looking to ways to reduce the administrative burden for Medicaid programs. So beyond the low reimbursement rates, we know that some of the sticking points are delayed reimbursement, claims processing. Is there any strategies that you're aware of that your states are employing to looking at reducing those administrative burdens from the Medicaid programs?
may I answer that quickly?
Yes, of course.
Okay. The Ohio Dental Association, as a member benefit, convenes what we call a Medicaid working group. And that Medicaid working group's purpose is to advocate for these issues or for our members regarding these issues. And we have been able to engage the Department of Medicaid. We've been able to engage the managed care organizations and take these concerns to them. Now, is that always successful? Maybe, maybe not. But at least our voice is being heard, and we do have a definite portal for communicating rather than just, sitting in our offices complaining about it. There is a communication, pathway to try to do that as a state association on behalf of our membership.
And I can add a little bit to that, in terms of, because Pennsylvania is the state on this call that hasn't officially raised our rates yet. We do have an increase coming in January, not 93%, but a little bit. And so we are hoping that will improve. But we have also heard from a number of providers that, our credentialing process with having 6 managed care organizations is bulky. We've been very successful. Our current governor was able to really refine the enrollment as a provider at the state level. So now we can turn those enrollments around in about a week. Now you still have to get credentialed with the MCOs, which of course takes a little bit of additional time. But we're now, starting to look at, is it possible that we can follow the path of other states and do a universal credentialing process that would get someone signed up with maybe all 5 MCOs that are offered in their area all at the same time, and hopefully make the whole process a lot less burdensome for them.
Yeah, from our perspective in South Dakota, certainly we've had some issues in the past with provider credentialing just due to Medicaid revalidation. But that's something we've certainly strived to make that as simple and quick as possible. And we've gotten the processing time down tremendously on that. And then certainly not having MCOs and having a dental vendor in South Dakota, who also is the primary dental insurer of many South Dakotans. Certainly, when we're developing policy changes or looking at implementing things, we are trying to align with commercial coverage and try to make that coverage for Medicaid as seamless as possible and as similar to commercial coverage as possible.
Thank you. And Dr. Haljeter, sorry, coming back to you. This is a good sign. This means that providers are interested on this webinar in figuring out how to accept patients because they're asking about your patient mix. What is your patient mix, first of all? What are your late no-show policies? And would you say because Ohio runs on MCOs, that the fee increase that has gone up is going to the MCOs, but then is being passed on to the dentists for reimbursement of services? And the last question is, I know you all are doing universal credentialing in Ohio or single process credentialing for all your MCOs and how that's going. I can remind you of that last question because I know I'm asking you quite a bit.
Well, how that's going. There are bugs, and I'll leave it at that. Anytime you introduce something new, there are going to be, hitches and bumps and things like that. I can tell you that credentialing has been a challenge for us, and still there are some challenges. It's gotten better, and especially with the unified credentialing. But again, things that we're working on, things that we're trying to address through that Medicaid working group. When we get anecdotal information from the providers that say, well, it's taken me 6 months to get my associate or 6 months to get whatever credentialed. Well, that's a problem. We don't want that. If someone wants to be a Medicaid provider, we want them to be credentialed as quickly as possible to get them into the mix of providing that care. So that's a very big deal for us. From my perspective, I can say that I think it's improving. It's not where we want it to be. As far as the question about the policies and no-show rates, again, we have a written office policy. 10 minutes into the appointment, we have the right to reschedule, or we reserve the right to reschedule the appointment. If the patient hasn't shown. Again, I I tend to be more of a softie, so I'll say, oh, it's okay. Well, but strictly by the policy, that is our policy. 2 missed appointments, you can be your status as a patient in our practice can be reevaluated, and if there tends to be a habitual missed appointment type of a trail, then usually that will get you dismissed from the practice.
And do you know your payer mix by any chance, percentage wise, or what percent of your office chair time is scheduled for people who are insured through Medicaid?
I want to say it's about 40%.
Okay, that's great. That's really great to hear.
Yeah, I mean, and I know we're running out of time, but I just want to say that, because of the increase, because of the fact that there is a need, I was one of the outliers that actually became a provider for an additional MCO recently, trying to do my part to increase access to care. Now, can we take every patient who comes in? No, we still have to limit it just because, and we didn't even get into workforce issues and things like that. But trying to do as much as we can in our capacity to try to help, and I invite other providers in Ohio to do the same.
The last question, and then I'll talk about a summary. But this is to all panelists, did you glean insight into who is the effective messenger for dispelling these myths of cancellations? The messages illuminated in the study are so helpful. Does it require dentist to dentist communication, or what are the best pathways to communicate all of these new initiatives that are helping improve the adult dental Medicaid benefit?
Can you hit the high points of that, Matt, one more time?
Yeah.
I think I
So,
missed part of
who do you think are the best messengers to illuminate about changes in Medicaid? Is it dentist to dentist? Is it the state to the dentist? Or is it the insurer to the dentist?
No.
What are you finding from your groups?
It's going to be dentist to dentist.
Mm-hmm.
You need a colleague. I need to be the colleague who says to my other colleague that this is the right thing to do. This is how I feel like I'm doing a better job in treating the patients in the community who need this. This is how it's benefited my practice. I'm speaking as a peer versus another entity that might not have the same relationship. So my first pick in those choices you gave would be dentist to dentist.
Mhm. Well, thank you everybody for joining us today. Sorry that we could not answer everybody's questions. I know there are more. What I will tell you is there were questions about the reimbursement rate comparisons. We do have that for fee charges as well as to fee for service rates on ada.org/HPI. That is where also the slides and the webinar will be present. We also will have and include in the follow-up messaging the one-page sheets of this webinar. Again, thank you so much for being a part of this webinar today. As you know, part of ADA's mission is improving the oral health of America. And so in order to do that, we need engaged stakeholders like you to improve the adult Medicaid dental benefit, as well as getting people to understand the new complexities and new benefits that come with it. So thanks again, and have a great and happy holiday season.